Ladies and gentlemen, good afternoon. Thank you very much for this invitation, Professor Dylan and Vikas. You've just heard two topics where we have most of the answers to ankle fractures and talar fractures. This is an area where there's a lot more controversy. There's a lot more change that's going on. There's a lot of research that's going in. And hopefully in the next 10 minutes, I'll be able to highlight some of the key points that we are discussing in the realm of calcaneal fractures. Now, this is very much a disease of the young, middle-aged, active male. Constitutes about 2% of all fractures in adults. The large proportion of these are intra-articular as opposed to extra, and they are largely, fortunately, closed injuries. Now, Singapore, where I come from, is famous for chili crab and the night Grand Prix. But also what they're famous for are big buildings. And because of these big buildings, you have a lot of industrial workers that have come from overseas. And these are the people who unfortunately fall off scaffolds. In my personal series, in the last 2 years, we've had about 52 out of 62 of these patients sustaining injuries from falls. So that's a very common mechanism of injury. And almost half of these patients, even after some kind of fixation, never quite get back to what they were doing before the actual injury, because they are largely industrial workers, scaffold workers. They have heavy loads going through their leg, and they are unable to resume their normal activity. I ask for no forgiveness going to the very basic, because I think this is important to try and understand. We all know about the different processes surrounding the calcaneum. You have the sustaneculum, which is the prominent process on the medial side, and the various tuberosities. The two joints that we talk about, restoration of which is very important around the calcaneum, is the subtalar and the calcaneocuboid joints. Now, this is where things get a little bit more complicated. The facets of the subtalar joint, the ones that we look at the image intensifier and try and reconstitute, are not often, is not always, a straight line. They are orientated very differently in relationship to each other, and those different facets contribute very different segments or very different roles to the weight bearing of the subtalar joint. And so appreciation of this and appreciation of how the talus sits on the calcaneum is very important when we're trying to reconstruct the joint. So coming back again to the very basics, taking a basic history, finding the occupation, the mechanism of injury is very important, because these are all very valuable markers to the eventual prognosis of the patient. We all know this. You're all very senior surgeons in the room, and you've seen this lots of times. But examination of the femur, knee, and the spine as a result of the mechanism of injury is very, very important. Now, the last statement on that slide, compartment syndrome of the foot, and examining the contralateral foot, I'd like to expand on. Margaret McQueen, in one of her biggest series about 2 years ago, looking at lower extremity compartment syndrome, coined the prevalence of compartment syndrome of the foot as high as about 4%. Yes, it is rare, but it does happen. And more so in the last sort of 15 years, we're beginning to appreciate that the foot has got various compartments to it. The latest cadaveric results would suggest there are about 9 compartments, and the deep central compartment is the one that's affected by a calcaneal fracture. Of course, blistering is something that often delays us from doing operations, and this is often a relative contraindication, if not a delaying factor for eventual ORIF. We all know about different X-ray views. The lateral of the hind foot is important to look at overall alignment, and Krish has just talked about the concomitant incidence of talar process fractures. These are important to exclude. The Harris axial view is very important to look at the orientation of your sustanecular screw when putting it from lateral to medial, Broden's view for the subtalar joint, and of course the AP and lateral of the foot and the ankle respectively to look at the eventual orientation of the joint. In my practice, I rely very heavily on CT scans. Now, these are two angles which come up over and over again in the literature. I must say that certainly as a community, the foot and ankle surgeons, we do acknowledge that restoration of angles are important, but it's becoming a very important research marker to look at outcome of different interventional modalities. And I'll come back to this a little bit later. Now, this is the fragment that we've always assumed is constant. Yes, it is a supromedial fragment which often doesn't move when there's a calcaneal fracture, and everything else crumbles around this constant fragment. There is some work that has gone on in the literature recently in the last 6 months from Korea, which suggests that even the constant fragment does actually move. But for all intention purposes, for the principles of reconstruction, we rely on the constant location of the supromedial fragment to build everything onto this fragment. Broden's view for subtalar joints in slight internal rotation, and of course the CT scan, like I alluded to. I rely very heavily on this, not only to look at the number of fragments, but also to look at the orientation of the fragments, one in relationship to the other. The orientation of the fragment and the number of fragments help me decide what kind of interventional modality I require after, and perhaps more importantly, how to plan my surgical reconstruction. So these are the three usual views we look at. The picture on the right shows the depression, which we all are very accustomed to appreciating as a prognostic marker and as the severity of it. But also more and more, we are acknowledging that the overall shape of the calcaneum is very, very important to dictate the eventual prognosis. And I'll come to this later on a subsequent slide. This is probably the second most important slide in my presentation. I think understanding why fractures the calcaneum behaves in a certain way is absolutely crucial. It is the load of the talus, the lateral process of the talus extruding into the calcaneum, which results in this primary fracture line. The eccentrically directed force results in a fragment that generates supromedially and another fragment posterolaterally. And it is wedge-like action of the talus onto the calcaneum that results in your primary fracture line. Then you have a supromedial and a posterolateral fragment, and the hindfoot is in eversion. Some people have habitually a little bit more hindfoot eversion, and they have the tendency for that sort of fracture pattern is to have a slightly smaller supromedial fragment in relation to the posterolateral fragment. Of course, as the force gets bigger, if the talus extrudes into the calcaneum with a much larger force, you can get a secondary fracture line, and as a result, you can get different variations of that with either a joint depression type or tongue type, Essex Lopresti type injury. You have other associated fracture types. I won't go into this into detail, but just to say that anterior process calcaneal fractures can be very, very difficult to pick on a clinical examination and even sometimes on x-rays. And in these kind of injuries, if you have an element of doubt, then you should do a CT scan. Okay? So this is a historical timeline of the treatment of calcaneal fractures. Going back in the end of the 19th century, you used to have bandage and elevation going into traction, and it was not really till the last 2 decades that Benushka and Sanders coined the lateral extensile approach, which is something we are focusing on a lot at the moment. This is a statement from one of the more important papers back in the 70s, looking at the role of non-operative treatment. Even at that stage, they acknowledged that the results weren't as good. And this you've probably all heard of several times before. This is the one paper that gets quoted again and again, a prospective trial from Buckley in Calgary, looking at the role of operative versus non-operative treatment. And it was from this paper that a lot of prognostic markers that came about. We're beginning to acknowledge that males with high load of physical activity, smokers and those on compensation claims, don't seem to do well than the other cohort of patients. Let me tell you what I do. So in my practice, non-operative treatment has a very limited role. Those with undisplaced fractures, very severe open injuries where soft tissue is a concern, if they have other concomitant life-threatening injuries, or significant soft tissue blisters that do not warrant an operation even within 2 to 3 weeks, are the ones that I treat non-operatively. And by far and large in my practice, this probably constitutes about 40% of calcaneal fractures. So what happens to the rest? Well, before I expand on that, non-operative in my definition, and certainly this is reciprocated by a lot of the literature, is about early range of motion. It's a bit like Achilles tendon injuries and ankle fractures. We are very much focused on early range of motion. Non-weight bearing, usually between 6 weeks to 3 months, depending on the fracture personality. I use a compression stocking early on and convert them to a boot at about 4 to 6 weeks. Of course, I acknowledge that non-operative treatment has a high risk, and that's why selection of a group of patients who you know will do well with non-operative treatment is just as important. Varus hindfoot with a lack of medial support, shortening of the foot, and peroneal impingement is the problem. Now, operatively, we are acknowledging that there's more and more newer techniques. The principles behind is anatomic reduction and understanding how to reconstitute the shape, restoring anatomy and getting them to restore their function and prevent subsequent arthritis. This is what operative intervention aims to achieve. And within the first 3 weeks of the injury, if the swelling allows, you get a Jones bandage off and then put them up for surgery. So what does operative intervention actually include? Now, these are, broadly speaking, the 3 options as far as operative stabilization is concerned. And let me touch on that. In the past, it used to be indirect reduction with either traction device or Gassan spike. And these were good for slightly less comminuted fractures. And also, it still stands hold today that if you have an avulsion type fracture like this, they do well with percutaneous fixation to try and restore the tension. This is one of the biggest studies early on looking at the role of percutaneous fixation of intra-articular fractures. And this is something that's definitely gathering momentum. Just want to draw your attention to the 3rd point on this slide, complication of infection, superficial and deep. I'm going to tie this up. Now, operative reduction, these are the 3 main goals: avoidance of varus, restoration of calcaneal height, and restoration of anatomical congruity. I'll just skim through this because most of you have done this before. This is the lateral extensile approach and reapplying of the plate. Now, this is what I do. I think more and more percutaneous reduction is the way forward. You have small stab incisions on the lateral side of the foot, and by far, majority of these fractures, whether the joint depression or comminuted variety, can be handled this way. And that's a picture of a subtalar arthroscopy-assisted fixation of the same fracture. So the future lies in percutaneous fixation. Subtalar arthroscopy does help, but restoration of the shape is just as important, if not more important, than restoration of the joint line. Okay? Subtalar arthrodesis is another option. I'll skim through that. And I just want to conclude by saying operative intervention aims to restore articular congruity, also the shape and alignment. Operative treatment is important to go in at the right time. And with open approaches, if you're going to do them, it should be a lateral extensile approach. In the future, most of these fractures will probably be dealt with percutaneous fixation, plus or minus with subtalar arthroscopy. Thank you.
Thank you. May I now invite Krish to come up? Those of you who are wanting details of this operative procedure, there's a book with a DVD of the operative available with JP Brothers on calcaneal fractures. So you can take it tomorrow. It's got a DVD by Buckley himself, the one who's done the maximum work.